Thank you very much for the introduction and for the opportunity to speak here at the conference. I'm going to talk a little bit about elderly and frailty issues in Denmark. I'm not going to talk about the specifics of how we handle and deal with frail patients. I'm rather going to talk about how we are transforming our healthcare system to delay the onset of frailty and how we focus on empowering elderly and frail citizens to be able to stay in their own home longer and to participate in their own disease. So I'm going to start with an introduction to the Danish healthcare system so you understand the setting. Then I'm going to talk about the transformation initiatives that's going on right now. I've been working with healthcare for more than 20 years. And right now I think we have the most exciting situation in Denmark with a lot of different initiatives from the Ministry of Health in cooperation with the healthcare regions and municipalities, which are together driving transformation of Danish healthcare. I'm going to talk about elderly care. I'm not going to talk about long-term care facilities because in Denmark we regard all elderly care as home care. That's a strategy and that's a way to involve and empower citizens. I'm going to talk a little bit about initiatives aimed at frail elderly patients, and then I'm going to talk about chronic patients because actually the chronic patient projects I see typically it's elderly patients, sometimes it's frail elderly patients participating in those projects. So the Danish healthcare system is a universal healthcare system with a focus on free and equal right to healthcare services. That means that when we have paid our taxes, all healthcare is free for all Danish citizens. We do have 16% out-of-pocket payment. That's primarily for dentist services and some medicine until reimbursement kicks in, and also for psychological services. The healthcare system in Denmark mainly consists of the Ministry of Health, Danish healthcare regions, which owns and runs the hospitals. And the regions are responsible for all hospital services. They're responsible for managing the primary care actors, the GPs and the specialists who are private enterprises but have more than 90% of their income from the regions. And until 2007, we had 15 counties which had the role of the regions. Today we have 5 healthcare regions because we had a healthcare reform in 2007 with the aim to create bigger units in healthcare in order to create the framework for making transformation happen. In the same way, in 2007, we went from 271 municipalities to 98 municipalities. It's easier to have 98 bigger units participating in transforming the healthcare system. With that reform, municipalities got a bigger responsibility for rehabilitation because we want to make rehabilitation happen closer to the patient, not in the hospital. They got a bigger responsibility for prevention and population health initiatives. And they got to control some of the money and the income of the hospitals in order to create the incentive for the municipality to do more prevention, more rehabilitation. If they do that, they will save on their patients and citizens going to hospital. So that was the introduction to the healthcare system. Now, if we look at the situation which is faced by all countries, and definitely 28 countries we have been talking to in Healthcare Denmark, they have those same challenges. You all know what they are: demographics, lifestyle issues, more treatments. And if you talk to the Danish Ministry of Health and they are in a bold mode, they will say, we need to change our healthcare system. We need to deliver healthcare in a different way. If we don't, we won't have enough tax money to pay for the healthcare our citizens want when we get past 2020. So this is about moving healthcare closer to the citizen. It's about discovering serious diseases like cancer and chronic conditions earlier. It's about screening. It's about population health and prevention initiatives. It's about intelligent nursing homes as ambient assisted living. And it's even about personalized medicine and personalized care, which I'll talk a little bit about. And if we talk about the patients, we heard the previous speaker talking about the hospitals. The previous speaker said it's a hazardous place for the patients to be in, and it's the most expensive place you can be in the healthcare system. Therefore, for a decade, we have had a focus in Denmark to do more healthcare outside the hospitals. Therefore, today, average length of stay in Danish hospitals is just below 4 bed days, and the ambition is to get down to 3 bed days. We have doubled the number of outpatient surgeries because we want to do more of that kind of services outside the hospital. We can do that because now the municipalities offer the rehabilitation. So you can go and have your outpatient surgery, and then you can get rehabilitated by help of the municipalities. We are focusing on using technology to cut down the average length of stay. A lot of focus on logistics in the hospitals, because what we see is that often you wait for a lab test or the specialist is not there, and therefore you spend 1 or 2 days more in hospital than you need to do. So based on this, the Danish Ministry of Health has launched a number of initiatives. The latest initiative, which came out last year, was a $200 million investment in detecting serious diseases earlier. It's called the sooner the better strategy. It's about ensuring that if there's a suspicion of cancer, you can immediately go to a hospital the same day to find out, is it a cancer or not? And if it's a cancer, then there are guidelines to ensure you get the optimal treatment. But another initiative which came out before that is the Healthy Life for All, which is a focus on prevention, reducing, it's on smoking cessation and alcohol reduction, it's on mental health. It's also looking on inequalities in healthcare, because what we're seeing in Denmark is that all the campaigns, all the initiatives, it works very well for the well-educated part of the Danish population. But those who are not so well-educated, they may not even understand what advice they get from the DP. And if you have social issues, you may be in the same situation. So we're actually trying to spend some of the savings on good behavior on part of the population to get the other part of the population on the wagon. And that is the purpose of the Healthy Life for All strategy. Then we're focusing on mental health. We are investing a lot in building new mental health facilities and modernizing those facilities. And the latest initiative which is going on right now is the Dementia Initiative 2016-2025. It's actually led by the Prime Minister of Denmark, and the reason is that we're seeing that while we have 80,000 dementia patients in Denmark currently, we expect that to more than double when we get to 2040. So the Prime Minister is getting different groups together over this autumn to devise a strategy to do more to address the dementia issue. It's about getting the right diagnostics at an early stage, because if you look at dementia patients, they may not even have the right diagnosis today, and then it's more difficult to treat them in an optimal way. It's about home and surrounding, supporting them. It's definitely about using relatives and next of kin more as a resource around dementia patients. It's about integrating care, connecting healthcare and social care, and it's about looking at nursing skills for dementia patients. So those are some of the initiatives which are being taken these years to accelerate the transformation of Danish healthcare. And one of the things we are fortunate to have is actually to have nationwide sharing of data. It started in 1994 when a guy in one of the counties at that time found out that nurses and doctors were spending more than 30% of their time handling administrative tasks, finding the latest lab results, the latest discharge letter, the latest prescription, or the medical record. So he thought, well, maybe the time is to do something and use electronic technology in this area. So he went to the Ministry of Health and said, if we can communicate all these messages electronically, if we had an electronic health record, we could potentially save 30% of nurses and doctors' time, and that could be spent on treating patients instead. And that idea was well received. So in 1995, the initiative started in Denmark to make a national health data network a reality. By 2002, 60 to 70% of all prescriptions, discharge letters, lab results, reimbursements, and a lot of electronic data in DP and hospitals were electronic. So somebody said, well, if we have all this electronic data, why don't we use it to empower our patient and give them insight into their medical condition, and also use it as a resource for clinicians. So that was the onset of the National eHealth Portal. And today, I can access the National eHealth portal. I can look up all my medicine overview. I can renew a prescription electronically. I can order my medicine as a pharmacy. I can have an e-consultation with my GP. I can look at my medical history, all contacts with hospitals and diagnoses back to 1977 when we started building these databases. I can look at the latest clinical note from the hospital and the GP, and I can see all my lab results on a nationwide basis regardless of where I went. I can also see referrals and following my referral and how it's acting against that referral. So this is where we are today, a national e-health record for the whole Danish population and national e-prescription, national lab results, and so forth. So where we want to go is actually to use those data to make telehealth a reality. Create a situation where telehealth is no longer pilot projects, but something that is offered to any chronic patient who can benefit from telehealth. And we are just in the phase where we have finished a number of large-scale projects for COPD patients, where one of the regions have offered telehealth to be offered to all the COPD patients in the region. They're going to report on that at the middle of November, and it's actually one of the largest research projects going along to build the benefit. And the reports we're getting right now says that it increases quality of life. It's saving a lot of hospital readmittance, 30 to 50% of hospital readmittance, and it's also prolonging the life of the patients. We'll see in a month. Other projects have actually reported their findings, and some of them were not so good in terms of health economy, but they were very good in increasing quality of life. And the reaction from the Minister of Health was that he said, I don't care if we're not saving according to those results, but improving quality of life is a priority for me. So we are going to be more aggressive on the target. I'm going to work on setting a national target to have telecare support for all COPD patients in Denmark implemented by the end of 2019. So that is another process that is ongoing as I speak. And the interesting thing is also that we have all the healthcare actors behind the Ministry of Health, Danish healthcare regions, Danish municipalities. They stand together and say, we want to make this strategy happen. Along with this strategy, there's also a strategy for assisted living. And that is kind of the same purpose. It will take a longer time to make a reality. But it's about taking all our experience from pilot projects and scaling up the very good examples to be implemented nationwide. We have already had, as far as ceiling lifts is concerned, targets for municipalities to implement ceiling lifts in all home care homes, simply because we can see that there's such a good business case. It saves so many nursing resources. It empowers the patients that you don't need 2 nurses to go every time, and maybe even the patient themselves can assist. And when we're pushing healthcare closer to the citizen, we also realize that the role of the hospitals will change, and therefore we are building 16 new hospitals in Denmark. We're renewing 1/3 of our hospital bed capacity. 8 greenfield projects, 8 current hospitals being refurbished, and that is a $7.5 billion investment. And that is because we see that when you go to hospital, you will have more comorbidity, you will be in more serious condition, you will need all the specialties a hospital can offer, and you will also need a closer cooperation between these specialties. So with this new hospital construction, we also change the role of all other hospitals. So a general hospital in a city, they are either getting specialized in 1 or 2 areas, or they change the role to an acute care hospital. And in that process, we cut down the number of hospitals from 98 in 1999 to currently 40 hospitals in Denmark. And we are aiming to get down at 30 when we have the new hospitals built. That's a national reaction and process when we're doing more in primary care for our patients. And then I mentioned the ambition to introduce personalized medicine. It was actually announced last year by the Danish regions which runs the hospitals. We're in a position to do that because we have those nationwide data. I mentioned nationwide lab data. We also have clinical databases. We have a wealth of data about the Danish population, even going back to 1977. And we have a national biobank with 16 million tissue samples, one of the most impressive biobanks. So that is the reason why, as a public healthcare system, we can embark on this strategy. So now the purpose is to describe the clinical genomics of 100,000 Danish citizens, to focus on cancer diseases and rheumatology diseases, because those are two diseases which are very expensive for the Danish healthcare system. And now the Danish Minister of Health also said, now the Minister of Health wants to embark too on this strategy. So that was something about transforming the healthcare system to ensure that when we get to the other side of 2020, hopefully we have enough tax money to pay for the healthcare everybody wants. Now I'm going to talk a little bit about elderly care, and this is really about connecting healthcare and social care. The 40 public hospitals with the 900 nursing homes we have, and ensure we connect the dots. And that's a challenge on its own. We are seeing this emerging. We are not perfect in Denmark, but we are working on making integrated care a reality. So if we look at where it all started, it started around 1937. Before that time, you depended on your family, or you could go to a home for the poor if you did not have a family or money. But in 1937 in Denmark, we started the employment of long-term care facilities. And in 1987, we realized that long-term care facilities and retirement home, where you just pay everything you have and then you are taken care of, that does not create enough empowerment. So we introduced the notion of home care, and we kind of looked at it the way that you're not going to a retirement home, you're going to a retirement community. And we look at three levels. Level A, you have your own home, but you have all the services available in terms of nurses and 24/7 and the care you need. B, you're kind of in between. You have home care, nursing support, you have some services. And C, you're almost living in your own home, but you have some facilities to help you. And if you look at the situation in 2005, we had 24% of those over age of 80 still living in retirement homes, but the strategy has worked, and we are moving away from retirement homes to a setting where we say you have your care in your own home. Your own home can be different according to those levels, but that is the principle on how we deal with the elderly in Denmark. And definitely, this is about being as long as possible in your own home. And if you look at the trend from 2006 to 2012, you can see that those over 885 and over 890, we have increased the number of that part of the elderly living in their own home by 8%. So more than 70% of those over 890, they actually live in their own home and get care and support through home nursing and a close contact from that system. And this is even changing now, where we not only in Denmark are talking about living in your own home, but living as long as possible in your own life. Being able to be empowered and decide for yourself how you want to live as long as possible. This is about patient empowerment. It's about tailoring the social care. It's about holistic approach to citizens' life situation, understanding the individual citizen and what they need. It's definitely about integrated and coordinated and planned care. And imagining all patients and citizens, more than 70% needing that care in their own home, that means that we need to have a close communication between the healthcare actors. So as part of the health data network, we actually also have electronic messages flowing between hospitals and the home care system. So when a patient goes to hospital, an electronic message is sent to help the coordination. When the patient leaves the hospital, a message is going the other way. And what we are seeing is actually, if we look at lengths of stay at the Danish hospitals, it's actually the elderly part of the population where the biggest increase has been 22% reduction of average length of stay from 2008 to 11, compared to only 15 and 13% reduction from other age groups. So this focus on supporting elderly patients, getting them out of the hospitals and into primary care as soon as possible, it's actually working as planned. Having thousands of home nurses supporting elderly patients also means that you need to use technology to coordinate this, and therefore many of them use mobile devices to plan their visits so they have the optimal route and spend less time on the road, to get information about the next patient, to document the things they do, to monitor patient self-management, to record new activities, and even to find out, hey, this patient is getting out of line, we need to set up another support scheme because the condition is worsening, or if there's other factors. So that's part of to make this possible. We need to use technology to really make this home nursing support happen. And definitely we get a lot of benefit from the health data network when it comes to medicine, because today everybody in the healthcare sector have an overview of a patient's medications. That's not only GPs and hospitals, but that's also home care. And as you know, medicine is definitely a risk for elderly patients. This is just 1 or 2 years ago that we realized that now everybody had that national overview. So there's still a way to go, I believe, before we have cleared all hazardous medicine and optimized all medicine for elderly patients. But at least we have the prerequisites for making that happen. Another area where we see the interest of technology and where we're using technology in Denmark is to create medicine compliant for patients. And I'm personally very impressed by this project because it was actually a designer who said, well, I'm reading so much about the hazard of medicine for elderly patients, there must be something I can do. So he designed this pill box because, you know, we have these pill systems that help monitor compliance, but many of them need reloading by professionals, and therefore it's creating too much of the workforce to make it happen. So he thought, can I make something simple that helps solve this problem? So what he invented is this pill box where you can have both medicine from the pharmacy, unit dose medicine, you can have injections, any medicine that an elderly patient needs to get. And on the top, you have a display which is connected through the DSM network, where from the EMR systems at the municipalities, they can set up the regime on when to take certain medicine. It will beep and give a warning, and the elderly patient just have to push a confirmation button to confirm that they take the medicine. This was brought on the market in January, and now already 14 municipalities are using it. 2 weeks ago, Gartner Group had it on their list of 5 disruptive technology in healthcare. So simple, so cheap, solving a big problem. Definitely also the use of technology in general is on the agenda in Denmark. We have a lot of living labs. We have groups of patients who help test new technology. And the technology is moving out from those living labs into new patient homes. One example is this floor. You may think, well, this is a floor and so what? But it's actually a floor with sensors which will sense whether a patient has fallen or whether that patient has got out of bed. So if you are living in one of those category A, where they really need to be able to see what's going on with the patient, they can use that floor. Another example are, of course, the ceiling lifts. A third example is a toilet, which is able to help the patient get on the toilet and get cleaned without any help. Other examples are completely remote controlled doors and window blinds. I visited a 93-year-old dementia patient who was so delighted that she could open the door herself, she could invite her guest, and in her home she had the ceiling lifts, she had the toilet. So we're really doing a lot of effort to test technology because we know we will rely on that with this home care strategy and then bring it out into new smart homes. The interesting thing is that when I visited this home with the 93-year-old patient, I had a group of international delegates with me. And one of them asked the workers and said, what do you feel about this? Are you working here because it's a way to earn your money? And she said, no, I'm working here because I make a sizable difference for our elderly. So I think working with new technology, working with new advanced patient homes also motivate people to work in healthcare and have that view. It's not only to go to work, it's really to help our elderly citizens. And they were very impressed because, as one of them said, if we asked in the US, we would never find somebody who would give that answer. So frail elderly citizens, well, one of the things we did was that in 1996, there was a law on preventive home visits, mandating every municipality to have a home visit to anybody over the age of 75 one time a year to do an assessment of their condition, and in order to ensure that we capture those in need of extra assistance. In 2001, the Elderly Association of Patients in Denmark did a study, and what they saw was that there's scientific evidence that this assessment process has considerably reduced the mortality of elderly. It has considerably reduced the number of admissions to institutional care, and very sizably and to extreme amounts for the frail elderly. There were no reduction in patient visits, and it's believed that this is due to the fact that you save some patient visit by this process, but you also find out, hey, there's actually a patient who needs to go to hospital, and maybe you improve the whole condition because they go to hospital earlier. We are also working with this area in the hospital sector. We don't have a law or any national structure, but a lot of geriatric departments work on screening for frailty, focusing on dementia, nutrition, and fall risk. I think they're using the Bartel scale primarily in Denmark for this kind of work. And finally, I'll talk a little bit about chronic patients, because the chronic patients I've met in the projects have typically been elderly or frail elderly. In one project in the municipality of Lyngby in Copenhagen, they took the approach and say, okay, here we have a chronic COPD patient. Now, if we did not have a healthcare system, if we did not have hospitals and clinics, how would we structure healthcare services around those patients? And they found out, well, it's about connecting the dots in the current healthcare system. It's about establishing a call center, so when anything get out of line, they can contact and have a consultation immediately. And it's about introducing some new resources focusing on COPD patients. And if you meet those patients, they will say, well, before this project, I kind of looked at my calendar and I had this appointment with a specialist, this appointment with the hospital and so forth. Today my calendar is blank because I have my pill box, I have my tablet, and I control my condition. I can use my spirometer, I can use the data in my tablet from the National eHealth system, and I can judge my own situation, I can adjust my medicine. If it gets out of line, I can contact the call center immediately. If it's serious, the nursing team will talk to me or go to me. If it's even more serious than that, they will put me into the acute, subacute unit at the municipality. And experiences from that project so far is that they're saving more than 60% at readmittance. But I think the real value of this project is that they empower the patient. One example was that there was one patient last summer that contacted the call center. He was out of line. He had a consultation with the doctor, and only when they finished the consultation, they found out that they were sitting in Florida. That's one way to empower the patient, because it's mobile technology. They have the pill box, so now they can travel. And then you might ask, well, this kind of technology, are elderly people able to use telehealth solutions? Yes, they are, and at least a proportion of them. And then we need to be aware of those who are not suited for this kind of technology. We need to use more resources to get them on the wagon. One reason is that according to the Danish digitalization strategy in general, all citizens need to have an electronic mailbox by November 2014. And we saw a bigger proportion of the elderly actually getting that mailbox and getting the tablet, finding out, well, I can also use this tablet to have a video conference with my grandchild. And it was actually fewer of the younger people, because they would rather use Facebook to communicate, that went on time. So I hope this was inspiring, our focus on transforming healthcare and elderly care in Denmark, and thank you for your attention.